Hello everyone, my name is Hiddo Heerspink and I'm a clinical trialist based at the University Medical Center Groningen in the northern part of the Netherlands. The CMF is a free educational resource for clinicians, and this podcast that I will do together with Professor Donnelly aims to keep you up to date with the latest information and data presented at the EASD meeting in Stockholm on renal and cardiovascular diseases in diabetes. As I mentioned, I'm joined today by Richard Donnelly.
Hello, my name is Richard Donnelly. I'm Emeritus Professor of Medicine in the University of Nottingham in the UK, and I'm also Editor-in-Chief of Diabetes, Obesity and Metabolism. Hiddo and I will be discussing some specific presentations at the EASD and also discussing some of our own personal highlights and reflections on the conference.
Let me then start with the first presentation. And this presentation and brief highlight that I will do is around the new drug called tirzepatide. Tirzepatide is a GLP-1 receptor agonist, and it is approved now in Europe and in the United States for the treatment of type 2 diabetes. A post-hoc analysis of one of the trials with tirzepatide focused on kidney outcomes, and that study I would like to discuss with you. In this study, the SURPASS-4 trial, tirzepatide was compared with insulin glargine in almost 2,000 patients who had inadequate control to type 2 diabetes and were at high cardiovascular risk. The primary outcome of that trial was the change in HbA1c from baseline to 52 weeks, and that change in HbA1c was significantly greater with tirzepatide compared to insulin. The effect or the difference in HbA1c after 52 weeks treatment was around 1% with tirzepatide 10 mg or tirzepatide 15 mg. The proportion of participants with hypoglycemia was lower with tirzepatide compared to insulin, and MACE outcomes, and MACE is defined as a composite endpoint of myocardial infarction, stroke, or cardiovascular death, was not increased with tirzepatide compared to insulin. Now, this pre-specified post-hoc analysis evaluated the effect of tirzepatide versus insulin glargine. The trial had two endpoints, pre-specified endpoints: a GFR decline of more than 40%, renal death, progression to end-stage kidney disease, or new onset macroalbuminuria. 64 participants in the tirzepatide arm, 6.4%, and 105 in the glargine arm, 10.4%, experienced this outcome. So overall, there was an almost 40% relative risk reduction with tirzepatide compared to insulin. However, this endpoint included a surrogate, namely new onset macroalbuminuria. And when we exclude this surrogate from the overall endpoint and focus on a clinically more relevant endpoint, namely 40% eGFR decline, end-stage kidney disease, or renal death, the risk reduction was somewhat attenuated to 0.20% and was no longer statistically significant. We have seen similar data with the other GLP-1 receptor agonists, where the endpoints, the renal endpoints with inclusion of macroalbuminuria was statistically significant, but when we exclude that endpoint, the effect size is somewhat attenuated. When we then look at the other endpoints, like eGFR decline 40% alone, there was a 14% relative risk reduction with tirzepatide. Renal death hardly didn't occur in this population. When we look at end-stage kidney disease, probably the most important patient-oriented endpoint, there were no patients with tirzepatide that experienced that endpoint and 5 with insulin. And then new onset macroalbuminuria occurred most frequently. 25 patients with tirzepatide, 61 with insulin. So the different endpoints all favor tirzepatide, but the magnitude of the effect was largest with macroalbuminuria, the surrogate endpoint. Nevertheless, these data were met with high interest by many people and support new trials that focus on the long-term benefits of tirzepatide on kidney function in these patients with type 2 diabetes. When the eGFR decline was evaluated and assessed, there was a significant reduction in the slope of the kidney function decline with tirzepatide. Overall kidney function decline was about 4 mL per minute in the insulin glargine group, and it was about 2 mL per minute with tirzepatide. So a reduction in the rate of decline per year of about 2 mL per minute. Also, the albuminuria was significantly reduced with tirzepatide compared to insulin by about 36%. And the authors who presented this data, including myself, also focused on other SURPASS studies with tirzepatide, and that reduction in albuminuria was also seen in other studies with tirzepatide, indicating that it's most likely a real effect and support future trials to assess the long-term kidney benefits of tirzepatide in patients with type 2 diabetes and chronic kidney disease.
I'm curious to know, Hiddo, to what extent those differences could be explained by differences in blood pressure or differences in body weight?
That is a really good question. The study actually was published last week in Lancet Diabetes. And in that publication, you will find an analysis where the treatment effects were adjusted for changes in HbA1c, changes in body weight. We didn't do that adjustment for blood pressure, but at least adjusting the treatment effect for the differences in A1c and body weight did somewhat attenuate the effect on kidney function, but only a small part. So that would suggest that the mechanism for protection with tirzepatide is not fully attributed, only for a small part, to differences in A1c and body weight, and that there are other mechanisms, perhaps directly related to endothelial function, perhaps related to reduction in glomerular hyperfiltration, that can explain these long-term benefits or these benefits observed over 2 years treatment on kidney function. Richard, can I ask you a question? How do you foresee this data for your clinical practice? Do you think that the tirzepatide will have a major role in the future for the treatment of type 2 diabetes?
Well, for sure. I think there's much more awareness these days about detection and prevention of renal function decline in patients with diabetes, and indeed those with pre-diabetes and obesity. So I think the focus on screening and early detection will also inform choices of therapy, recognizing that end-stage renal disease or cardiovascular death associated with renal disease are fairly major outcomes to be avoided in the long term. So I think people will look with great interest in these drugs going forward.
Yeah, we have moved from a glycemic-centric point of view more and more to organ protection. That was my feeling as well when I attended the EASD this year again. So much emphasis and so much data around the protection of the heart, the protection of the kidney, the liver. Obesity appears to play a more and more important role rather than only glycemia.
Yeah, I think payers, organizations like NICE, have clearly expressed that they want data on prevention or amelioration of diabetes-related complications, not simply lowering HbA1c or body weight. So we're going to see big cardiovascular and renal outcome trials, which will provide, hopefully, some very powerful information on the use of these agents longer term.
Yeah, it's interesting that you mentioned that. And also, when we think about obesity at the EASD, the company that developed tirzepatide, Eli Lilly, announced a big outcome trial, SURMOUNT MMO, in 18,000 obese individuals. It's a cardiovascular outcome trial. And these are huge programs. And I understood from the presentation that they not only focus on cardiovascular outcomes, but also kidney outcomes, NASH outcomes. So again, looking at the organs and also looking at the organs in combination, the kidney, the liver, the heart, and they're all connected, I believe.
Very good. We should move on to the second presentation.
Yes, our time is limited. Thank you for informing me. So the next presentation I will briefly discuss was a post hoc analysis of the semaglutide program, and specifically 2 clinical trials, Sustain 6 and Pioneer 6, were analyzed, and the effects of semaglutide by baseline kidney function were assessed. So the trial, Sustain 6 and Pioneer 6, were 2 cardiovascular outcome safety trials designed to prove the cardiovascular safety of semaglutide subcutaneous or oral administration. And this pooled analysis assessed the effects of semaglutide by baseline GFR and albuminuria. And here you see the risk of patients with a lower GFR or higher albuminuria. And no surprise, as seen in so many trials and cohort analyses, the lower the GFR, the higher the risk of cardiovascular outcomes, which is demonstrated here on the left in the slide. And the higher the albuminuria, the higher the risk for cardiovascular outcomes. And that remains true even when we adjust for all kinds of baseline characteristics that may be different in these different subgroups. But the question then is, do these patients with a low GFR also benefit from semaglutide treatment? And here in the top row, we see that in unadjusted analyses or in adjusted analysis, again correcting for potential differences in baseline characteristics, the benefit of semaglutide in preventing cardiovascular outcomes remains present even in people with a GFR below 45. And when we look at baseline albuminuria, we can also appreciate from this slide that the benefit of semaglutide is more or less consistent also in people with higher albuminuria levels. Now, important to recognize that the vast majority of these events occurred in people with the highest albuminuria levels, so that the absolute benefit that you can derive from semaglutide treatment is higher in those with higher albuminuria levels. And this again underscores the importance for screening for albuminuria to identify patients at risk of progression. And now we have the tools in hand to treat these patients with high albuminuria, either with GLP-1 receptor agonist, but probably also with the drug we just reviewed, the GLP-1 receptor agonist, or with other interventions such as SGLT2 inhibitors. So interesting data, more or less expected, because we've seen it from other programs as well, that GLP-1 receptor agonists and that cardiovascular benefit, or at least safety, is consistent across baseline GFR and albuminuria data. But again, important to confirm this finding for a drug which is often used in practice.
Yeah, it carries similar messages, doesn't it? People have often thought that SGLT2 inhibitors are the only therapies that will protect the kidney, but actually there is quite significant data that in appropriate patients, GLP-1 agonists may have their own renoprotective effects, albeit mechanisms still not entirely clear.
Yeah, I would agree with that, and we'll see more data from the FLOW trial in next year, a little bit more than a year, a dedicated kidney outcome trial with semaglutide. And in that trial, 15% of patients are using an SGLT2 inhibitor at baseline. So it gives us the opportunity to also assess effects by baseline SGLT2 use. So and then the question for the future, I think, for clinical practice will be which drug for which patient, and perhaps which combination of interventions, GLP-1, SGLT2, we have the finerenone, the mineralocorticoid receptor antagonist, and can we find the right combination? Because I don't think we can treat all patients with all medications, because that would increase the pill burden too much and could decrease adherence. Shall we move on, Richard, to our third trial? And that's the trial that you're going to present, the DELIVER trial, a big outcome trial in heart failure patients.
Yeah, so I attended this session at EASD, which was really to discuss the DELIVER trial. The results of the DELIVER trial were presented very recently at the European Society of Cardiology Congress and were published simultaneously in the New England Journal of Medicine. But at EASD, the focus was on a number of pre-specified analyses. So we know from previous clinical trials that SGLT2 inhibitors reduce the risk of heart failure hospitalization and cardiovascular death in patients who present clinically with heart failure and have a reduced ejection fraction on their echocardiogram. What's been less clear is whether SGLT2 inhibitors also improve outcomes in that group of patients who also have clinical heart failure, but have a more preserved or mildly reduced ejection fraction. The DELIVER trial involved 6,200 patients with heart failure who had an ejection fraction above 40%. And these patients were randomized to dapagliflozin or 10 milligrams once daily or placebo. And the primary outcome of the DELIVER trial was to look at worsening heart failure or cardiovascular death. And the median follow-up was 2.3 years. I should say that in the context of the background to this trial, there were a couple of other relevant features. We knew with empagliflozin from the Emperor Preserved trial that there was potentially some benefit in patients with less impaired ejection fraction. But there was a suggestion from Emperor Preserved that as ejection fraction increased, that the benefits of empagliflozin diminished. So that was also part of the justification in the DELIVER trial to explore those groups of patients with normal or mildly impaired ejection fraction. As I mentioned, there were over 6,000 patients randomized to dapagliflozin or placebo. 45% of them had type 2 diabetes. 45% of them also had a body mass index above 30 kilograms per meter square, and about 57% of them were in atrial fibrillation. Clinically, about 3/4 of these patients had New York Heart Association Class 2 symptoms, and their baseline ejection fraction was 54%. The trial also included patients who'd been recently hospitalized with heart failure. About 10% of the study participants had recently been hospitalized with an episode of heart failure. And 18% of these study participants had heart failure where their ejection fraction had previously been reduced, but had now been improved. This slide summarizes the primary outcome measure for dapagliflozin versus placebo. And you can see that there was an 18% relative risk reduction in favor of patients treated with dapagliflozin versus placebo. And of course, that was administered as add-on therapy to usual care. When you break down the primary endpoint into the two components, worsening heart failure on the left and cardiovascular death on the right, you can see that most of the benefit was achieved via prevention of worsening heart failure. That included urgent or emergency hospitalization due to a worsening of heart failure symptoms. And the effect of dapagliflozin on all-cause death showed a 6%, albeit not statistically significant, reduction in relative risk. So to summarize the DELIVER trial, dapagliflozin 10 milligram once daily as add-on to usual care significantly reduced the composite outcome of worsening heart failure or cardiovascular death versus add-on placebo. And this was in a patient population with mildly reduced or normal ejection fraction, but who had clinical evidence of heart failure symptoms. Dapagliflozin reduced both components of the primary outcome. And it was also clear that total events and the number of symptoms were also improved in the dapagliflozin treated group. In terms of tolerability and adverse events, these were similar between the two groups. So at the European Association study, there was further presentation of some of the pre-specified analyses out of the DELIVER trial. And the first of these was presented by the Glasgow group, in which they provided a pooled analysis combining data from the DAPA heart failure trial, which of course recruited patients with a reduced ejection fraction, combining those data with the DELIVER trial, where they'd recruited patients with normal or mildly reduced ejection fraction. And you can see on this pooled patient-level meta-analysis that overall, dapagliflozin reduced the risk of cardiovascular death and all-cause death. Certainly cardiovascular death, the relative risk reduction was 14% and a 10% reduction in all-cause mortality. So fairly impressive results. Interestingly, that beneficial effect of dapagliflozin was not modified by baseline ejection fraction. So whereas with empagliflozin and the EMPEROR preserved trial, where there appeared to be a relationship such that higher levels of ejection fraction tended to diminish the therapeutic benefit of empagliflozin, in this combined analysis, looking at the relationship between the benefit of dapagliflozin on primary endpoints and the spectrum of ejection fraction found across the DAPA heart failure trial and the DELIVER trial, it would seem that the benefits of dapagliflozin applied right across the spectrum of ejection fraction. In other words, clinically, it doesn't matter what the ejection fraction is. If the patient clinically has the symptoms and signs of heart failure, they will obtain the mortality benefits from adding dapagliflozin 10 milligram on top of usual care. So the summary of that meta-analysis from the group in Glasgow showed that in this combined analysis, dapagliflozin reduced deaths from cardiovascular causes, total mortality, as well as total hospital admissions, irrespective of left ventricular ejection fraction. So that indicated that most patients with heart failure, regardless of ejection fraction, will benefit from add-on treatment with an SGLT2 inhibitor.
Richard, I believe these are very important data. Before we are going to briefly discuss further subgroup analyses, there was always a question, are SGLT2 inhibitors also beneficial in patients with heart failure and preserved ejection fraction? Because so many drugs have been tested in these patients, and often, while they were effective in patients with reduced ejection fraction, they were not so effective or not effective at all in patients with preserved ejection fraction. This is, I think, the best evidence we have, that combined analysis that demonstrated that regardless of ejection fraction, you will derive the benefit from, or you will obtain the benefit from an SGLT2 inhibitor. So I think it's crucially important question that was addressed.
You make a good point, Hiddo, that of course, we're all familiar with the mortality benefits of ACE inhibitors and beta blockers, but of course the outcome trials with those drugs were all confined to that group of patients with heart failure and reduced ejection fraction. But many of our patients with diabetes particularly tend to fall into that group of heart failure with preserved ejection fraction. And up until now, we've had very little data at all to show any mortality benefits from any therapy. So this carries major impact in terms of improving outcomes for a very large population of patients with heart failure whose ejection fraction is preserved. And it also makes life much easier for primary care physicians and others who don't therefore need an echocardiogram in order to optimize therapy.
Yeah.
If the patient in front of you has signs and symptoms of heart failure, they're going to benefit from the addition of an SGLT2 inhibitor. Waiting for an echo is not necessarily going to change the clinical decision. So that certainly makes clinical practice easier to implement.
Yeah, definitely. For the sake of time, Richard, we have to go quickly through the many other subgroup analyses that have already been done. Important to know, the main results of DELIVER were only published a month ago, and there's already so many other additional analyses, but let's run through them quickly.
Yeah, sure. So the first one was focusing on those patients in DELIVER who'd actually recently been hospitalized for heart failure. And again, it showed the benefits of dapagliflozin were consistent across that group. There was a subgroup analysis according to age to really focus in on whether the benefits of dapagliflozin also applied, particularly in elderly patients over the age of 75 years. And the answer to that question is yes. The third analysis, which was presented at the European meeting, related to the presence or absence of diabetes and glycemic control. The slide here focuses on body mass index. And you remember that 45% of these patients had a BMI above 30. And again, the benefits of dapagliflozin applied not only in obese patients, but also in less obese or non-obese groups. But interestingly, in respect to glycemic control, they divided the DELIVER population into three groups: those who were non-diabetic, those with pre-diabetes, and those with type 2 diabetes. And the data shown at the Congress was that the benefits of dapagliflozin applied again consistently across all three glycemic categories. So it would seem that irrespective of ejection fraction, irrespective of body mass index or diabetes status, and independent of recent hospitalization for heart failure, active treatment with dapagliflozin conferred benefits on symptoms and survival.
Yeah, these data underscore many other aspects that we already knew from SGLT2 inhibitors, but now in patients with preserved ejection fraction, namely that the benefits are present across a range of patients, thick or thin, high or low HbA1c, high or low ejection fraction, high or low kidney function. It actually doesn't matter, which makes life in clinical practice pretty easy, because many patients will benefit. And the safety is also consistent in many patient subgroups, in particular the elderly, which was an important finding, I think, from the DELIVER trial and in line with other studies.
Indeed.
So we have seen some interesting new data from the clinical trials presented at the EASD. Richard, were there any other highlights for you apart from these trials that we just discussed?
I was interested in some of the data around diabetes prevention. There's obviously a lot of interest in obesity and a lot of interest in pre-diabetes. And I was taken by an analysis by Dr. Garvey and colleagues who combined data from the STEP 1 and the STEP 4 trials with semaglutide. And they used a prognostic formula known as the cardiometabolic disease staging tool to predict the 10-year risk of type 2 diabetes in these patients with obesity. And they provided very strong evidence that active treatment with semaglutide as an anti-obesity agent may halve the risk of these patients developing type 2 diabetes over the next 10 years. And I think more and more attention will switch in the next few years to diabetes prevention.
Yeah.
And these agents are beginning to demonstrate that not only will they reduce body weight and reduce BMI, but they might also actually prevent some complications of obesity, top of the list being the development of type 2 diabetes. So I thought that was quite a striking analysis, which gives a flavor of, again, the sort of information that payers will want to see in the context of obesity therapy.
But you mentioned this with semaglutide. Semaglutide reduces HbA1c in these patients. So is that just because we reduce HbA1c and thereby delay the onset of type 2 diabetes, or do you think that there are other glycemic independent pathways, improvement in beta cell function, insulin resistance that could play a role?
It may be all of those. So there may be something about modifying fat distribution such that these patients are less diabetogenic.
Yeah.
There may be a little bit about improving insulin resistance.
Yeah.
There may simply be that by achieving 10% body weight loss, patients become more mobile and are able to do more physical activity.
Yeah.
I'm not sure that the mechanism matters too much.
As long as you can
take a group of people who have a very high risk of deteriorating into type 2 diabetes over the next few years, and you treat them and you at least postpone the onset of type 2 diabetes, that's a major benefit.
I fully agree. You mentioned insulin resistance, and one of my highlights was a nice lecture, the Minkowski lecture, about brain insulin resistance. Dr. Heine from Germany did a fantastic presentation about the role of brain insulin resistance and the development of diabetes, which was completely novel to me, with very nice imaging studies that he conducted over the last couple of years. And I recommend those who have access to the virtual meeting platform from the EASD. And if you haven't listened and heard that presentation, to listen it in the coming months. So with that, I'd like to thank everyone for listening to us and to listening to this review of the EASD. I hope you have enjoyed the podcast, and you can let us know what you think by leaving a review at the CMF website. And then, Richard, I'll leave it to you to do the final closure.
Yeah, thank you for listening. And you can find much of this information on the CMF website. Bye-bye.
Bye-bye.